Only stick and stones can break my bones. Otherwise, a trivial trauma can, and a trivial trauma is enough to break every bones. So our next lecture is about like weak bones, osteoporosis, neglected endocrine disorder, and the talk is being delivered by Dr. Harsh Durgia. I'm welcoming Dr. Harsh Durgia on podium.
Thank you, Apia. Good afternoon, everyone. So, after many talks, like now we will move on to osteoporosis. It's a bit of a theoretical topic, but it has immense practical implications. So this is the comparison between a normal bone and osteoporotic bone. This is a microarchitecture of normal bone on the left side, and on your right side it is a osteoporotic bone which has its trabecular mineral depleted, bony plates and connecting branches are lost, and even you can see that it is a weaker bone. So this will be the flow of my talk. We will discuss about bone remodeling, osteoporosis definition and epidemiology. Then we will see just causes of secondary osteoporosis. Then we will discuss diagnostic modalities of osteoporosis, and finally we will go on to discuss treatment. So bone remodeling, just a word on it. Bone remodeling cycle is tightly coupled, where bone resorption and bone formation usually go hand in hand. And this remodeling unit comprises of two main cells, that is osteoblast, that is bone forming cells, and osteoclast, that is bone resorbing cells. Why this is important? Because for treatment, we'll need this information. This is the chart showing when the peak bone mass is achieved. Peak bone mass is depicted with green line, and the violet line is suggestive of bone formation, and yellow line suggests of bone resorption. So as you can see, there is peak in the bone formation during the puberty. There is pubertal spurt, and this is the reason why peak bone mass is achieved in between 15 to 25 years of age. And after that, for good 20-25 years, as you can see, this both lines converge, that is resorption and formation go hand in hand. And this continues till menopause, and after menopause there is spike in the resorption. Formation also increase, but they are unable to keep pace with each other, and the both lines diverge. Resorption is more than formation. This leads to the loss of bone mass. As you can see, the dip in the bone mass after menopause. So this is basically primary osteoporosis. Two types of osteoporosis are there, primary and secondary. Primary is because of, as a result of aging or menopause. So it's postmenopausal as in females, and senile osteoporosis as in males. Secondary osteoporosis is usually due to medications and pathological conditions other than aging which affect bone mass. So this is just a comparison of bone mass of a 20-year-old individual, 50-year-old and 80-year-old. You can clearly see the bone loss over the years. Osteoporosis is defined as low bone mass, deterioration of bone tissue, and disruption of bone microarchitecture. It can lead to compromised bone strength and increased risk of fracture. It is a risk factor for fracture, just as hypertension is for stroke or diabetes is for retinopathy and nephropathy. And like diabetes, it is a silent disease until fractures occur. Coming on to epidemiology part, approximately 30% of all postmenopausal females have osteoporosis in US and Europe, and at least 40% of these women and 15 to 30% of men will sustain one or more fragility fractures during their lifetime. This is the 2017 US data, and as you can see, the prevalence of osteoporotic fracture is more than stroke, heart attack and breast cancer combined. Still, it is less, we work up less on this. It's a neglected disorder. This is the prevalence from India, and as you can see, the prevalence is more or less same as the global prevalence. Nearly 1 out of 3 postmenopausal women have osteoporosis. Now coming on to the males, it's understudied population. Males are usually understudied as far as osteoporosis is concerned. But this 2013 study has shown that around 9% of the otherwise healthy males aged more than 50 years suffer from osteoporosis. In nutshell, 1 in 3 women and 1 in 5 men over age 50 will experience osteoporotic fractures. And despite marked advances in the management of osteoporosis, very few will receive treatment. And the sad reality is that even after suffering fragility fracture, the treatment is less common. This gives the notion of neglected endocrine disorder to osteoporosis. Now coming on to osteoporotic fractures, vertebral fractures are the most common manifestation of osteoporosis. They are hallmark of osteoporosis. The other osteoporotic fractures include hip fracture, pelvis fracture, proximal humerus fracture, and distal wrist, that is Colles fracture. And women are far more likely to suffer a Colles fracture than men in the ratio of 10:1. Whereas for hip fracture and vertebral compression fracture, this ratio is 2:1. And hip fracture is the most dreaded complication of osteoporosis because it not only affects quality of life, but it has also shown to increase the mortality. Coming on to risk factors, like any non-communicable disease, osteoporosis also has a modifiable and modifiable risk factors. So non-modifiable include age, as we have already seen, female sex, ethnicity, genetics, and peak bone mineral density. And modifiable risk factors include nutrition, calcium and vitamin D intake, lifestyle factors such as smoking, alcohol use, what level of exercise patient is doing, and use of medications. Body weight lower than 60 kg significantly increase the risk of osteoporosis in women. That also is a risk factor. Now moving on to secondary osteoporosis, here only, like we will discuss only causes in short. So endocrine disorders that have shown to be associated with secondary osteoporosis include diabetes mellitus, hyperparathyroidism, hyperthyroidism, hypogonadism, and Cushing's syndrome, etc. Autoimmune disorders such as rheumatoid arthritis, IBD, lupus, multiple sclerosis, GI disorders such as celiac disease and weight loss surgery, they have also shown to be associated with secondary osteoporosis. Hematological disorders such as leukemia, multiple myeloma, thalassemia, neurologic disorders such as stroke, Parkinson's, etc. have been shown to be associated. Then breast and prostate cancer, osteogenesis imperfecta, we have just seen in the previous talk that it is clearly associated with osteoporosis. AIDS, HIV, COPD, liver disease, CKD, all these are causes of secondary osteoporosis. Now coming on to the medications that are related to osteoporosis. Antacids, proton pump inhibitors, cancer drugs, anticonvulsants, pioglitazone, and most important out of this is glucocorticoids. Long-term use of glucocorticoids in the dose of even prednisolone more than 5 mg, if used for more than 3 months, can lead to loss of bone mass. Moving on to diagnosis, how to diagnose. So we usually measure bone mineral density for diagnosis, and it is like measured or by the occurrence of fragility fracture in absence of major trauma. So the trauma should be trivial for diagnosis of osteoporosis. It is measured usually by dual X-ray absorptiometry, that is DEXA scan. These are various modalities that can be used to measure bone mineral density, that is X-rays, ultrasonography, DEXA, quantitative CT, and MRI. But DEXA is currently the standard of care. It gives good measure of bone mineral density. And in DEXA also, we should do central DEXA, that is bone density of hip and lumbar spine, which is used for diagnosis. These are various machines, DEXA machines, which are used to measure bone mineral density. And finally, like we measure BMD in gram per centimeter square, but finally what we compare is T-score. T-score is a comparison of patient's BMD with that of a healthy 20 to 29-year-old female. And Z-score, on the other hand, is comparison of patient's BMD with that of a similar age and sex person. T-score is used in patients who are more than 50 years of age, whereas in young adults or in children, Z-score is used for diagnosis. Now, who need bone density measurement? So, these are the Indian guidelines. Women aged 60 or men aged more than 65 should be advised DEXA scan, and this is regardless of any clinical risk factors. This cutoff is 5 years lower than the Western cutoff as per the National Osteoporosis Foundation, that is Western guidelines suggest 65 years cutoff for females, but Indian cutoff is a bit lower because age of menopause is 46 years in Indian females, which is lower than the Westerners. Now coming on to the postmenopausal females younger than 60 years or men younger than 65 years. In those also you can do DEXA scan if there are other clinical risk factors such as low body weight, prior low trauma fracture history is there, or if there is history of high risk medications such as glucocorticoids. Individuals who have had fragility fracture before age of 50 years should also be advised DEXA, or those with secondary conditions such as rheumatoid arthritis, diabetes, or taking medications such as steroids. So these are the indications to do DEXA scan in our routine practice. Now, which area to test? So we usually see bone mineral density as lumbar spine, that is L1 to L4. We should omit deformed vertebra, and at least 2 vertebra should be measurable. On hip, we see neck of femur or total proximal femur is measured. Third side that we measure BMD is forearm, that is distal 1/3 of radius. But we should avoid using or measuring forearm BMD except when hip and spine BMD cannot be measured, or in some specific conditions such as hyperparathyroidism, which affects distal radius more specifically. Now, the other tools that can aid in diagnosis is FREX, that is Fracture Risk Assessment Tool. It's a risk calculator for major osteoporotic fracture or hip fracture. It gives the 10-year probability of major osteoporotic fracture or hip fracture. This can also be useful in decision making when planning for treating these patients. So this is how diagnosis is made. T-score of -2.5 or below in the lumbar spine or femoral neck or proximal femur qualifies for osteoporosis. Low trauma spine or hip fracture, regardless of BMD, can be considered as osteoporosis. And if T-score is between -1 to -2.5, that is osteopenia, in such patients, if there is fragility fracture of other sites such as proximal humerus, pelvis, or distal forearm, or if the FREX is high. And what is high FREX? If the 10-year probability is more than 3% for hip fracture and more than 20% for major osteoporotic fracture, we say that FREX is on the higher side. So in such type of patients also, treatment is indicated. Now, these are the mandatory tests to be done in all the patients with osteoporosis. Once we diagnose the osteoporosis, the laboratory investigations such as CBC, calcium, phosphorus, alkaline phosphatase, kidney function test, liver function test, and vitamin D and TSH. These are must. In some cases, we can also do PTH. Now, if you are suspecting secondary osteoporosis, then if the suspicion is for multiple myeloma, we can go for ESR or serum electrophoresis. Celiac, for celiac, we can do TTG, IgA evaluation. If patient is suspected to have hypogonadism, we can do testosterone or estradiol in females, LH, FSH levels, etc. Now, a word on bone turnover markers. They are not used for diagnosis of osteoporosis. They are just complementary to BMD measurement. They don't have any role in diagnosis, but can be used in monitoring because they are dynamic parameters. They reflect short-term acute changes, and BMD changes take time to occur. So while treating, you can use these parameters in monitoring. So reference standard marker of bone resorption is serum CTX, that is C-terminal telopeptide, and reference standard marker for bone formation is serum P1NP. So to summarize till now, does patient require treatment for osteoporosis? So we should measure BMD. If T-score is less than -2.5, you should initiate treatment. If patient is having fragility fracture, go for the treatment. If the T-score is between -1 to 2.5, then see the FREX score. If FREX probability for osteoporotic fracture is more than 20% or hip fracture is more than 3%, you should treat such patients. So just a short case. This is a case of 60-year-old female, postmenopausal since last 12 years. She was found to have osteoporosis on routine evaluation when she visited orthopedics for non-specific bone pains and was referred for further management. So this was the DEXA scan. This is how a normal routine DEXA scan looks like. So the L1 to L4 T-score, you can see it was -3.1. and on neck of femur it was minus 2.3. So like as L1 to L4 T-score was minus 3.1. So it was minus 3.1, so it classifies as a osteoporosis. So let's move on to treatment of osteoporosis. So these are the general guidelines for management of osteoporosis. We should maintain vitamin D levels above 20 nanogram per ml, and if possible, it should be between 30 to 40 nanogram per ml. We should supplement vitamin D and calcium, but the supplementation should be optimal, and we should avoid over treatment when this vitamin D and calcium is concerned. Then counsel patient to limit alcohol intake, counsel patient to stop smoking, and to have good physical activity. Lifestyle should be modified. Then major part of osteoporosis management is fall prevention, because though it is a low trauma fracture, but one needs to fall for fracture. Unless, other than vertebral compression, fracture can occur without fall. But for hip fracture, for wrist fracture, one needs to fall. So fall prevention is very important. Regular physical activity, resistance exercise for preservation of muscle and bone mass should be advised. And if the patient is having type 2 diabetes or type 1 diabetes, the patient should be advised to avoid hypoglycemia. So in such patients, we should be cautious while using sulfonylureas. We should avoid diabetic medications like pioglitazone, which are associated with bone loss. And adequate glycemic control should be achieved to prevent long-term complications such as retinopathy and neuropathy that also can lead to increased fall risk. Now these are the recommendations for calcium and vitamin D intake. Like calcium around 1000 to 1200 milligram per day is what is recommended, and vitamin D supplementation of 600 to 1000 international units per day is the recommendation. Now for calcium, like 1000 to 1200 is the total calcium required per day. Like it's not the supplementation, it's diet plus supplementation that should be 1000 to 1200. So if the patient is getting 500 milligram from the diet, rest 500 milligram we can give as a supplement. Moving on to pharmacotherapy. So pharmacological agents can be divided mainly into two parts, that is anabolic agent and anti-resorptive agents. Anabolic agents are teriparatide, abaloparatide, and romosozumab, whereas anti-resorptive agents comprise of bisphosphonates and denosumab. Out of bisphosphonate, we have alendronate, ibandronate, and zoledronate. And out of these three, zoledronate is the most potent bisphosphonate available currently. These are the doses of various agents that can be used. So for teriparatide, the dose is 20 microgram subcutaneous daily. For zoledronate, it is 5 milligram IV once yearly. And for denosumab, it is 60 milligram subcutaneous every 6 monthly. So these are the three main agents that we use in our day-to-day practice. We can also use alendronate, which is oral. It can be given daily or weekly. But again, it has its own side effects. It has to be taken daily. So for convenience and for better adherence, zoledronate is preferred. Now coming on to the guidelines. So this is the recommendation in postmenopausal women at high risk of fractures. The recommendation is initial treatment with bisphosphonate, and the note is made that ibandronate should be avoided because it is helpful in reducing only vertebral fracture. It has no effect on non-vertebral or hip fractures. Now denosumab can be used as an alternative treatment to zoledronate, and there are few things to be kept in mind while giving denosumab. It has to be given 6 monthly, and one should not skip the dose of denosumab, because if you skip the dose, the bone loss will be severe and the patient is again at risk of multiple fractures. So it has to be given every 6 monthly without skipping the dose. Now coming on to teriparatide, the recommendation is that in females with osteoporosis with very high risk of fracture, such as those with severe or multiple vertebral fractures, they recommend teriparatide for 2 years for reduction of vertebral and non-vertebral fractures. And this ceiling of 2 years was because of the osteosarcoma risk, but the real world evidence has shown that there is no major risk. So this black box warning was updated. It was removed in 2020, and a revision of this 2-year lifetime limitation was made. So the current recommendation is to use teriparatide for more than 2 years, only if the patient remains at or has returned to having high risk of fracture. Teriparatide may increase serum calcium slightly and can result in cases of hypercalcemia. Therefore, serum calcium should be assessed before initiating these agents, and they should not be used in those with hypercalcemia. A word on HRT. It's not recommended for managing osteoporosis due to high risk of side effects such as cardiac events and breast cancer. But in few patients who are having menopausal symptoms along with osteoporosis, you can use if there are no any other contraindications. Coming to monitoring, you should do DEXA of spine and hip every 1 to 3 years to assess the response to treatment. And as previously mentioned, bone turnover markers such as CT and FEV can be the alternative way of monitoring these patients. So coming back to the patient, she was treated with zoledronic acid IV annually for 2 years. Her lumbar spine BMD improved significantly. As you can see, the T-score was minus 3.1 to start with, which improved to minus. I think it's audible, right? Yes. So it improved to minus 2.7, and patient was advised annual follow-up. This is few of my research that I have published in last few years in osteoporosis. So to summarize, osteoporosis is a chronic condition yet undetected in majority. Hip fracture is the most serious consequence which can lead to morbidity and mortality. Proper management can decrease the incidence of fragility fracture, and endocrinology referral should be considered in patients with primary as well as secondary osteoporosis. If left untreated, morbidity and mortality can be immense. Diagnosis is easy to make. You can do DEXA scan. Evaluation is centered on ruling out secondary causes and doing proper risk stratification. And effective and safe treatment options are available, which can be helpful to reduce the fracture risk. So with this, I end my talk. You can take.